Welcome again everybody, this is Yasser from Learn Dental Series. Today we will continue and finalize our discussion about fundamentals of tooth preparation. Let me disclaim firstly that I don't receive fees, compensation or royalties from the sales of any of the products shown or discussed. Also, I declare that I haven't any conflict of interest with any of the discussed products and technique. Let me remind you that this presentation is copyright protected and could not be manipulated, reproduced, distributed, or transmitted by any electronic or mechanical means unless you have a written permission from me. Already we have finished part 1 related to definition and concept, part 2 principles of tooth preparation, part 3 biological principles in terms of bulb protection, prevention of caries recurrence, preservation of tooth supporting structure, and finally working in a completely aseptic field. And we started to discuss mechanical principles in terms of obtaining the outline form, performing resistance and retention. We already finished this discussion, and now we are continuing for the convenience form, step number 3 of mechanical steps of cavity preparation. Now we will discuss it in terms of introduction, definition, and what is the convenience forms or the convenience features. Let's start with the introduction. Imagine we have these 3 cases, typically the same, typically similar, and we asked 3 operators to prepare a cavity with definite specifications. What are these specifications? We need the cavity to involve all carious lesion, involve bits and fissures, and at the same time haven't any sharp line angles, okay, and at the same time the margins are in a self-cleansable area. The first operator, okay, trying to conserve the tooth structure and cuts the cavity as this, okay, it's absolutely right one, okay. Carious lesion and bits and fissures are involved. Cavity margins are extended just to area self-cleansable without endangering or without destruction of the tooth structure. That means that you already perform a maximum conservation of sound tooth structure. At the same time, all line angles are rounded. Okay, but the question now, is it a seeable cavity? Could you see all the details? You could inspect all the internals of this prepared cavity. How could he ensure that there is no recurrent caries, no caries, remnant caries? How he could condense the amalgam or insert the material inside this cavity? This is the question, okay? And these are our remarks for this operator. Then comes the second operator, okay? He cuts or prepared or designed his cavity as this, okay? If you re-examine or assess this cavity, okay, actually he involved all carious lesion, okay, he involved all bits and fissures, cavity margins are in area self-cleansable, okay, at the same time no sharp line angles. But he has already done 2 mistakes. Number 1, no conservation of sound tooth structure. He already done or had done massive destruction of the tooth. This is number 1, okay. Number 2, there is no definite walls. Where is the buccal? Where is the lingual? Where is the mesial? Where is the distal? Okay, you couldn't blame him. He already applied all the rules we asked him to follow in principles of outline form, okay. But actually, this is a massive destruction of the tooth structure. Although all the cavity details are seen, although you could assess and examine all the details of the internal cavity outline. But the third operator, okay, has designed a cavity just like that in between the 2 designs. Okay, it is not very narrow to an extent that you could not examine all the full details, internal full details of the cavity, and at the same time it is not massively distracting the tooth structure. And that's why we ask this question: which of these cavities is easily seen, easily reached, easily instrumented, and easily restored with maximum conservation of the tooth structure? This is the convenient one, or this is the convenience form of cavity preparation. That's why our definition is convenience form is the shape or form given to the prepared cavity to make it easily seen, easily reached, easily instrumented, and easily restored with maximum conservation of sound tooth structure. Then, what are the convenience forms? When you accentuate the line and point angle, when you extend the cavity margin slightly to facilitate insertion and condensation of the restorative material, when you round the axial line angles, when you bevel the enamel wall to provide room for burnishing for ductile materials like gold, okay, when you select a smaller instrument, these are convenience. And finally, extension for convenience, which is limited nowadays, okay, as we discussed before. We said that cutting occlusal portion to access proximal caries in class 2 is considered as convenience form, and the same for class 3. If you remember this plate, okay, the first one is class 2. You should access the proximal surface by cutting an occlusal portion, and this is considered as convenience form. Also the same, the second one is proximal class 3. You could access it by cutting in the palatal surface, because already both of them had a neighboring teeth which already act as an obstacle which blocks the access, okay, to the proximal surface. That's why cutting an occlusal or palatal cavity for compound proximal caries, okay, is considered as a convenience form. Then comes the most important step, is removal of remaining infected dentine. If you remember in our first discussion considering the mechanical principles in terms of outline form rules, okay, we discussed the terminology of remaining, because already our first rule in preparing a cavity was within the outline form, number one, all carious lesions should be involved. And if you remember, when I discussed this with you, I mentioned that this is concerned with buccolingual and mesiodistal caries extension, not caries in depth, not the third dimension of your carious lesion. That's why it is termed remaining infected dentine. Okay, and actually also I would like to comment on the terminology infected. Okay, previously this step number 4 was termed removal of remaining carious dentine. Now it is removal of remaining infected dentine. Okay, it may be it is cariously affected, not infected, and you let it or you left it uncut, okay, and you are sure it will not lead to recurrent caries. That's why our procedure now, okay, or this step of cavity preparation is limited to remaining infected dentine, okay, on the floor of your cavity or in the third dimension or in the depths. Firstly, you should differentiate between also two terminologies. What is dental caries and what is carious lesion? Dental caries is the pathological process of creating a carious lesion. Okay, it couldn't be stopped unless you remove all the etiological factors or the behavioral contributing factors of your patient. You should manage it, okay, with all its causative factors. Okay, but that's why we mentioned in our introduction to this topic that the aim of this topic is to design a prepared cavity for repair of defective tissues, not for treatment of dental caries. Okay, carious lesion is the defective tissue due to dental caries. That's that one which we should remove, and we should design a cavity to repair these defective tissues, okay, and prevent further defect of it. Okay, we will discuss this topic in terms of aims of carious tissue removal, routine cavity depths, conditions of at routine cavity depths, what is the strategies of carious tissue removal, what are the approaches of carious tissue removal, how could you protect the pulp after carious tissue removal, okay, instruments used for this purpose. Okay, when we discussing the aims of carious tissue removal, the old aim is to remove all carious lesion regardless the condition of the bulb, regardless preservation of the bulb, even you are exposing the bulb, and the case will be endodontics, okay, but you should ensure that all your cavity is absolutely clean with the normal color of healthy sound dentine, okay. Nowadays, okay, we are concerning with the health of the tooth. Nowadays, there are a new number of guiding principles that determine your aim in infected tissue removal. Okay? Number one, you should put in your mind to preserve non-demineralized tissues which are healthy, and even if it is demineralized, you should determine is it remineralizable or not. That's why our removal now is limited to remineralizable, unrepairable tissues only. That's why number one, you should preserve non-demineralizable tissues and remineralizable tissues, tissues which are defective but able to repair by remineralization. Number two, you are intended to achieve an adequate seal by placing peripheral restoration into a sound dentine and a sound enamel. Then, when you are discussing remove or not to remove, your walls and margins are out of this debate. Okay? It's a general rule. No debate, no discussion about it. The margins of your restoration should achieve and ensure adequate seal. That's why it should be absolutely clean from any carious lesion. Your restoration should be placed against sound dentine and the enamel to control any bacterial activity. Once you are ensuring peripheral seal, even if you are doubtful that there is bacterial activity at the base of your cavity, once you get enough seal, you're already denying your microorganism from its favorable substrate, from its favorable condition, from oxygen tension needed to multiply and reproduce carious lesion. Okay? Number three, avoid discomfort and pain and dental anxiety to maintain the bulbal health and preserving the residual dentine. This will allow you to reduce bulbal irritation. This will allow you to prevent bulb exposure, and all of these are favorable conditions for your bulb to repair or to heal. Then you aim to maximizing the longevity of your restoration by removing enough soft infected dentine to place a durable material with sufficient bulk and resiliency. That's why, okay, in our reviews, okay, our review or reviewing the previous studies, okay, leaving carious dentine beneath restoration means leaving softer bacterial contaminant demineralized dentine below this restoration. This was an old concept. It not only constitutes a need for recurrent caries, but also a bad substitute for bonding if you are going to restore the tooth with a bonded restoration. Okay? But this in controversy with what I mentioned 1 minute ago. Okay? You mentioned that undemineralized or non-demineralized tissues and repairable tissues that could be remineralized could be left. But now you said that leaving any doubt of this is a carious dentine, that means that you leave a bump under your restoration that may explode in a form of recurrent caries and also interfere with proper bonding when you are going to restore the tooth with bonded restoration. Okay? This is true. That's why when there is no risk for bulb exposure or bulb irritation, okay, there is no doubt that you should remove all carious dentine, not negotiating, not discriminating if it is infected or affected. Okay? Then, when you have enough dentine bridge, when you are not so deep, when there is enough dentine to cut safely and remove any doubtful dentine, go on and remove it. Okay? But when there is a doubt, then you should stop and negotiate. Should I leave it or should I remove it? This is the question, okay? But in routine cavity depth or at routine cavity depth, okay, in moderately deep cavity, you still have sufficient dentine to remove any doubtful defective tissue, okay, that may endanger the success or the prognosis of your restorative procedure. That's why you should determine what is called routine cavity depth. What is routine cavity depth? Routine cavity depth is calculated as 0.5 to 1 millimeter beyond dentino-enamel junction. You should go under the dentino-enamel junction by 0.5 to 1 millimeter. This is the minimal default routine cavity depth. Why? Okay. Why not at the dentino-enamel junction? Because this is a sensitive area, as we mentioned before in the topic of clinical considerations of tooth histology, okay, that this is a sensitive area. We shouldn't cut at this sensitive area, we should cut below it, okay, to get sure also that there is no undermined enamel, okay, resulted from the lateral spread of carious lesion at the dentino-enamel junction. You should be beneath the dentino-enamel junction to determine any lateral spread of dental caries resulting in undermined enamel, okay, to detect this lateral spread of caries, also to provide sufficient bulk and also to benefit from dentine, okay, as you remember the retentive features by utilizing dentine either to increase the undercut or to increase the length of walls for frictional grip, all the gripping action of viscoelastic vital dentine in case of using gold foil restoration. But when you cut a cavity, just stop at routine cavity depth and inspect or examine what is the condition of your floor. At this condition, the routine cavity depth, there are three possibilities or conditions you may discover. Either you have hard sound viable normal color dentine, or hard discolored dentine, or soft dentine. Hard sound viable dentine, this is the best condition. You finish the cavity, finish your enamel walls, apply either varnish or bonding agent according to your restoration, varnish for amalgam, bonding agent for composite resin restoration, okay? This is the best condition. Also, one of the best conditions are hard discolored dentine, okay? It is considered as sound dentine. Although it is discolored, okay, but it is hard. Once it is hard, it is considered as sound dentine. Okay, but it is discolored due to the chromogenicity, the colors arising from carbohydrates when metabolizing your collagen or carbohydrates. Okay, it's a discolored metabolites that discolored or entrapped inside dentinal tubules, but your dentine is absolutely hard and absolutely sound. Okay, previously they considered this as an aesthetic defect that may appear through your composite, and opacers are used just to block the color, okay? But nowadays the new systems of composite already having opaque dentine layers, okay, that block this color, okay, and it doesn't considered as any aesthetic defect or any aesthetic management. But the worst condition is you find soft caries dentine or soft dentine, which is painful, denoting the presence of viable protoplasmic processes, okay, and may be discolored or not, and this layer will constitute the floor of moderately deep or deep cavity. At this time, you should apply the previous guiding lines we discussed in the previous few minutes ago, okay, considering is it should be removed or not, because now we are dealing not only with defective tissues, but we are dealing with bulbs that should be protecting underlying these tissues. That's why we should determine the strategy of carious tissue removal. Again, remember our guiding principles. You need to preserve dental tissues, which is able to remineralize. The unremineralizable or unrepairable tissues should be removed. Maintain the bulb health, avoid bulb exposure, okay, avoiding pain and dental anxiety, provide sound cavity margins to achieve proper sealing. In other ways, it means that you need to make the environment favorable to heal the pulp and repair the defective tissues by remineralization. That's why you need to assess your carious lesion. Is it affected or infected? Histologically, when we need to differentiate between caries infected dentine and caries affected dentine. Caries infected dentine means that it is loaded by microorganisms and it is absolutely destructed, including demineralization and destruction of collagen network. This layer is the outermost superficial layer, irreparable, unable to repair. It is considered as absolutely necrotic zone. Clinically, it appears dark brown. It appears soft, wet, or mushy layer. Mineral components are absolutely dissolved away. Irreparable damage of collagen matrix. Your collagen matrix are already destructed. High bacterial load, destruction of the dentinal tubular pattern, okay, and should be removed totally. Caries affected dentine, it is the inner layer to the previous one and can be repaired because it is only affected by acid but not infected by microorganism. Okay, that's why it looks pale brown or paler brown or lighter brown. It looks or it feels more harder, sticky and scratchy dentine, less mineral dissolution, still have patent repairable collagen matrix, although it is damaged, but its damage is still repairable. Okay, less bacterial load, less destruction, and could be left. Okay, these are sections, okay, denoting that the outermost layer is the infected, mushy, wet one, and the inner layer is the affected one. Reviewing the histological zones of dental caries, okay, these 6 zones, first one, necrotic and the contaminated zone, are related to infected dentine. Histologically, affected dentine is the demineralized and translucent zone, because translucent zone is considered as a type of sclerosis, a mean of protective mechanism or defensive mechanism of the pulp. Then comes sound dentine and tertiary dentine. We removed only infected layer which contains histologically necrotic zone and the contaminated zone. How could we differentiate? Number 2, we could assess it by mechanically, by hardness, how it feels when you remove it, okay, and this determines which is infected and which is affected. You will feel 4 consistencies, 4 mechanical consistencies of dentine. Soft dentine, okay. Number 1, soft dentine, which is easily deformed when you just apply your hand instrument, which is the excavator, and could be easily scoped up with any sharp excavator with little or no force. This is soft dentine that should be absolutely removed, which is considered as the necrotic zone. Okay, then comes a less demineralized zone, still mineralized, okay, which gives it slight power or slight strength. It feels like leather. It's a leathery dentine. Does not deform easily when pressed with an instrument, but still could be easily lifted with much little force than the soft layer. Okay, still could be removed by the excavator. Then comes a firm layer, okay, which is resistant to hand excavations and it needs a massive force. It is much better. It's a layer that partially removed with excavator, but it needs massive force, okay, or a little more pressure with your hand, okay. And the final one is hard one, which is scratchy, having scratchy sound. It's very hard to be removed by excavator. Even if you apply pressure, it needs only round burr to remove it. The first 2, okay, we should remove it, denoting some sort of bacterial activity. Okay, they are considered as an infected zone, and firm and hard dentine could be left if you couldn't remove it to avoid pulp exposure. Okay, this photo showing the 4 types of dentine hardness, starting with A, soft, B, leathery, C, firm, and finally D, the hard one, and it is still discolored. Okay. The preservation of sclerotic dentine is the best way to protect the bulb. This is the best layer, absolutely tubular, or the dentinal tubules are blocked, or the pathway to irritate the bulb are pathways are blocked. Okay, and this is the best condition. Okay, it should never be removed, although it has a darkened color. Okay, ranging from brown to black, but it shouldn't be removed. It is very hard in probing, as it contains a greater amount of mineral, and radiographically it appears white, which is radio opaque, okay, at radiograph. Then comes your assessment, physical by color, okay, yellowish or slightly brownish dentine, okay, while the inactive carious lesion is highly stained, okay, while the active carious lesion tends to be lighter in color as it is active and it runs in a very rapid way. That's why it doesn't have any chance to be stained either by food debris or metabolites of microorganisms. Okay, active carious dentine, okay, should be removed, but by color it's unreliable and possibly affected by incorporating of external stains from the food debris. Maybe the dark one is active one, but according to if the patient is a smoker, if you heavy tea and coffee consumer, okay, this will result in misdiagnosis of the activity of carious lesion. Fluorescence, it's a way to diagnose the bacteria and the bacterial metabolites, okay, but sometimes bacteria may be hidden inside or sealed inside the dentinal tubules, especially if the cavity is deep, and escape from detection by fluorescence. Chemically, using CARIOUS detecting dyes that determine the collagen destructed by the action or loaded by microorganisms, but also it may be non-valid, okay, non-reliable, and may lead to risk of bulb exposure. Okay, that's why in summary, using the hardness criterion, okay, is the most reliable one to assess the carious tissue to be removed. Okay, and there is a wide belief that complete removal means removal until hard dentine is left bulbily, but nowadays reviews of literature, okay, was found to this is an over treatment that may lead to bulb exposure, and you are not in need to remove all carious defected dentine. You remove only unrepairable infected dentine. I'm sorry. That's why let us discuss the approaches to remove carious tissue. The first one is a non-selective removal up to hard dentine. This is the old concept. Okay, you are removing or lowering the bulbal floor, okay, non-selectively, all the bulbal floor, regardless it is soft or hard, okay, removal of all carious lesion. You didn't discriminate if it is infected or affected dentine. You should remove all of it until you reach hard dentine. This concept was called complete removal. Okay, this concept is controversial and did not follow the guidelines. It doesn't conserve the tooth structure. It doesn't save the bulb. It doesn't leave the repairable tissues able to repair. Then comes, okay, selective removal. But selective removal to firm dentine or selective removal to soft dentine. Selective removal means that you stop your cavity preparation at the routine cavity depths and just select definite areas to excavate up to reach leathery or firm dentine. Okay, in expense of your peripheral enamel and dentine should be hard and should ensure accurate peripheral seal. Okay, and this is a favorable condition. You already reached, okay, an affected dentine. But what is the approach if you didn't reach or you couldn't discriminate or diagnose or assess your dentine that is an affected layer or infected layer? This means that you are selectively remove till you reach soft dentine near to the bulb and avoid bulb exposure. Okay, this is called partial or incomplete removal. Then condition number 1, non-selective total removal or complete removal until you reach hard dentine. This is number 1. Okay, but this is now unreliable one, absolutely destructive. You didn't preserve repairable tissues which could be repaired by remineralization. You didn't save the bulb. Okay, you irritate the bulb. All of the conditions we discussed before, it is not following the guidelines we discussed. Then, to follow the guidelines, we, number 1, selectively remove only the defective tissues. Remove it with excavator until we reach firm dentine or leather dentine. It's acceptable result. Okay, but what about if we couldn't define or discriminate, okay, between affected and infected, and still we have soft dentine? The idea now is partial or incomplete removal, okay, which is discussed in terms of stepwise excavation or two-step excavation. What does it entail? Okay, it entails, number 1, selective removal of soft dentine as much as possible, but avoid bulb exposure. Okay, this is number 1. Then apply a provisional restoration that will help the tissue to be remineralized. Apply this material, let us say calcium hydroxide and glass ionomer material, okay, for up to 12 months. Step number 2, after 6 to 12 months, reopen it and selectively remove up to firm or leather dentine. In expense of, during this period, you follow up the case, and the case recorded no pain, no periapical pathosis, no discomfort, and vitality test revealed that your bulb is healthy, normal bulb. Again, remove as much as possible. Still you have soft carious dentine, but you don't like to expose the bulb. You don't like to refer the case for endodontist. The idea is to give a chance for your bulb to heal, to give a chance for your dentine to remineralize. Just ensure that you already protect your bulb and isolate your dentine with a material that enhance a favorable or achieve a favorable environment for bulb to heal and for your dentine to remineralize and repair again, in expense of you provide a maximum proper seal. Even if you are not sure that you already removed all the bacterial loaded tissues, but at least you decrease the bacterial population by removable mass of soft carious dentine. You already provide maximum seal, and as we mentioned before, this maximum seal denied your microorganism from oxygen tension, denied your microorganism from substrate, and it will stop its progress, and you will find a chance or create a chance for dentine to repair and to bulb to heal. That's why after 6 to 12 months, okay, you reopen it, reintervent it, okay, by selective removal to firm dentine. What ensures success of your procedure of this two steps excavation or stepwise excavation? Within these 6 to 12 months, you should follow up your case at definite time intervals. Number 1, patient do not complain or do not record any complaint about pain or discomfort. Okay, periapically by radiograph the tooth is free from any periapical pathosis, diagnosable pathosis, and by vitality testing the tooth is still standing vital. Okay, this is our approach. What is the bulb protection after caries tissue removal? At routine cavity depths, you are not in need for bulb protection. Already you still have the best protective material, which is dentine to your bulb. This is the best protective material and your bulb could pass safely. Okay, just apply varnish if you are using amalgam, or just apply bonding agent if you are going to use composite resin. For moderately deep cavity, still you have bulk of dentine protecting the bulb, but this bulk is reduced. That's why your bulb is subjected to thermal irritation, especially when you are using metallic restoration such like amalgam. That's why you need to protect your bulb by using cement-based material. Okay, but still you have a fair dentine bridge. But if you are going to restore the tooth with composite resin restoration, you are not in need for more than dentine bonding agent. In some cases, we may use glass ionomer cement just to reduce the amount of composite used, not to protect the bulb. Okay, but in deep cavity, you have here a great problem. You have already a very reduced dentine bridge. You denied the bulb from the natural protective mechanism of your dentine bridge. That's why you need to protect the bulb, your bulb, with cement base. But cement base at this level already could protect the bulb mechanically, could protect the bulb thermally, but by itself your cement base is considered as chemically irritant material due to its acidity. That's why you are in need for sub-base of alkaline material such as calcium hydroxide liner, followed by to be covered by zinc phosphate or cement base. Cement base will provide the bulb with mechanical and thermal protection, while calcium hydroxide is alkaline material will protect the bulb against the acidity of your zinc phosphate cement. That's why, okay, most of operator or most of you may ask, then calcium hydroxide is more effective than zinc phosphate? Absolutely no. Calcium hydroxide could protect the bulb chemically, but could not protect the bulb against mechanical and thermal irritation. That's why when you are going to restore your tooth with metallic restoration, such as amalgam, you are in need in deep cavities for sub-base and base. Sub-base to counteract the action of acidity of your base, and the base material just to protect the bulb against mechanical and thermal irritation. If you are going to restore your tooth with non-metallic restoration, just like composite resin, which is non-metallic, which could not irritate the bulb mechanically, or because it is not condensable material, it is not going to irritate the bulb thermally, it's a thermal insulating material. You need just to seal the very deep area with calcium hydroxide and apply your bonding agent and apply your composite material, because the composite is not a condensable material and calcium hydroxide could withstand the application of composite resin. But calcium hydroxide alone could not withstand the force of condensation of amalgam. When you apply amalgam and condense it, calcium hydroxide will be disintegrated or will be defragmented. Okay, this is a clinical view of a case. Okay, if you remember this case, we spot removed parallel to the recessional line to the bulb until we reached firm dentine and apply a base material. What are the instruments used for carious tissue removal? We used either hand instruments using excavator in a direction parallel to the recessional lines, from the periphery in a simple scoping motion, from the periphery to the center. This is the right side excavator. Then from the periphery to the center, okay, using left side excavator. Okay, it provides no heat generation and removes only defective tissues. This is the advantages of using hand cutting instruments in general. Rotary cutting instruments, we used large round burr because this round shape suits to be parallel to the recessional lines of the bulb with very low speed, without pressure, okay, under sufficient coolant water air spray. Okay, again, excavators are better than using rotary instrument because it cuts only, its cutting only is limited to removing carious tissues, and being a hand cutting instrument, there will be no heat generation. Finally, we are now in need for finishing of enamel and external cavity walls. Why you are in need to finish enamel cavity walls? Okay, just to give the correct cavo surface angle inclination, to remove any undermined enamel, to produce a smooth enamel wall, okay, and keep the rounded convenience outline form, okay, with proper cuspal contour without any sharp line angles. What are the requirements for enamel cavity walls? According to Noise, this is the first time we heard another name rather than GV Black. Okay, it's Noy, okay, who designed or assigned general rules or general guidelines for keeping strong enamel wall at margins. He mentioned that enamel wall must rest on sound dentine. Enamel rods which form the cavo surface angle must have their inner rods resting on sound dentine. The outer end of enamel rods, if it is not in the full thickness, at least it should be covered by high ductile material. That's why it should be beveled, okay, to establish a strongest enamel wall, just to be covered by gold inlay or gold material at this bevel. Enamel walls and margins should be finished smooth, free from any short, loose, friable or undermined enamel. Enamel wall must take the inclination of enamel rods, must be in the same direction. Enamel wall must have an inclination suitable with the physical properties of the restorative material, as we mentioned many times that cavo surface angle should be 90 for brittle materials and 135 for brittle materials to allow burnishing. Enamel wall must be beveled in case of using high strength restorative materials. What are the factors affecting inclination of cavo surface angle? As we could conclude, it's the direction of enamel rods and location of the cavity walls, friability of enamel, degree of marginal strength. Again, cavo surface margins for brittle materials as amalgam and composite should be 90. For ductile materials should be or could be 135 to allow burnishing of your gold material over a beveled margin. That is the margin that should be beveled, should be cut to be 90 degree and should be in the same direction of enamel rods. When you cut a gingival floor at this area, it is not in the same direction of enamel rods. That's why it should be cut just like this. Okay. When you apply this rule, you will discover that buccal wall will be parallel to the buccal surface to ensure that the cavo surface angle is 90. Lingual wall will be parallel to the tangent of the lingual surface, okay, to ensure you have cavo surface angle. That's why buccal and lingual walls will appear to be slightly converging occlusally, and at the same time this provides the required resistance and provides the required retention. While mesial and distal, the mesial wall will be parallel to the mesial surface, distal wall parallel to the distal surface. That is to ensure that this cavo surface angle will be 90, and mesial and distal walls will appear to be slightly diverge. Gingival floor is a very critical area. When you cut it with your burr, which is Fisher burr, it will appear to be straight, parallel to the pulpal floor, but actually histologically this is not the direction of enamel rods. That's why with gingival marginal trimmer you should trim it, okay, by this way. If you notice the right side photograph, it should be slanted downward using a gingival marginal trimmer just to bevel this margin. Beveling of enamel walls means that you are increasing the cavo surface margin more than 90. We have 5 types of beveling of enamel walls. Number 1, short bevel. Short bevel, that constitutes a part of enamel. Okay, this will give room to burnish the gold. Okay, this is done with indirect metallic restoration. Then long bevel, starting from the dentino enamel junction up to the cavo surface angle. Then full bevel, starting from the cavity floor, okay, up to the cavo surface angle. Then counter bevel, if you remember, when we have done it to protect weak cusp in case of using cast gold restoration. And finally reverse gingival bevel, if you remember, to prevent rotation or rocking of your gold restoration, indirect gold restoration around the axiopalpal line angle. As we mentioned, when force is applied like this, it will be transformed into or analyzed into two horizontal components, but the one to the outside is greater than that, okay, from the inside, and it will tend to displace your restoration, and your restoration will rock or will slide, rocking around the axiopalpal line angle. But when you've done a reverse gingival bevel, the two horizontal components will be equal to each other in opposite direction and cancelling each other, and the restoration will be stable. This reverse gingival bevel, if you remember, it is not indicated in case of amalgam, as it leads to stress concentration, mercury accumulation, and reducing the bulk of amalgam. All of these are factors that leads to excessive weakening of amalgam restoration. Then comes, or then we I would like to remember you that all bevels are made in enamel except reverse gingival bevel is made in denti. Then what are the functions